Good evening, everyone, and welcome to our first presentation in our NetCell's medical series. We're very excited to have you here this evening, and we hope you enjoy our presentation. Unfortunately, we have been hit by stage 4 load shedding, of course, just before our inaugural webinar. So please do bear with us if we have some connectivity issues. Carola, who will be presenting, unfortunately, is being load shed at the moment. She does have connectivity, but she will not be sharing her webcam as she is currently sitting in the dark. So we are sorry about that. But Dr. Carola Niesler will be presenting for all of you. She is the Chief Scientific Officer at Next Biosciences, and she is also a Professor of Biochemistry at the University of KwaZulu-Natal. So I hope you all have enjoy our webinar, and if you have any questions, please do send them through and we'll be able to address them at the end. Thank you very much, and handing over to Carola.
Right, thank you. Thank you, Shelley. So as Shelley said, welcome to the first webinar in our NetCell's medical series. And the aim of this series is to highlight new potential uses of umbilical cord blood in the clinic. And in tonight's presentation, we're going to be focusing on cord blood stem cells in the treatment of cerebral palsy. So perhaps just a disclaimer, I'm by no means a cerebral palsy expert, but as the scientific director at NextBio, I've got a keen interest in understanding how the scope of stem cell application can be increased to address current unmet medical needs. And I hope that at the end of this presentation, you feel that I've gone some way in addressing perhaps some new ways in which we can view cord blood and cord blood stem cells. The presentation tonight was put together not only by myself, but with the assistance of Shelley Bredin, who is the business unit manager of NetCell. So thank you very much, Shelley, for that. So let's start off with just a little bit of a background. Cerebral palsy refers to a group of non-progressive movement disorders. It's a lifelong condition and is actually the most prevalent motor disorder of childhood. And it's characterized by brain dysfunction, which leads to a general lack of muscle control. And there are many causes of the brain damage that is characteristics of cerebral palsy, including, for instance, hypoxia, infection, trauma, and others. It affects around 2 to 3 children per 1,000 live births, but this number can actually be higher in low resource settings. So the earliest description of cerebral palsy was back in the 1860s by the orthopedic surgeon, Dr. William Little, and so initially was actually referred to as Little's disease. It's a permanent condition and can be either congenital, where the damage occurs to the brain either prior or during or shortly after birth. It can also be acquired, although this is less common, and in this case the damage is far later after the birth. An interesting fact is that it's now thought to have a significant genetic component, with 14% of cerebral palsy cases thought to be linked to a single gene mutation. So critical regions of the brain which are affected during cerebral palsy, or that give rise to cerebral palsy, include the motor cortex. And the motor cortex helps to initiate movement, and so you can imagine why damage within this area would result in issues to do with movement. Basal ganglia, which receives impulses from the cortex and processes them, and is also therefore involved in gross motor function, and the cerebellum, which coordinates the voluntary muscles and so is critical in balance and coordination requiring activities. So depending on where the damage lies, the signs of cerebral palsy in childhood can be classified as spastic. So spastic cerebral palsy is the most common, and in this case the damage is prevalent in the motor cortex. And children with spastic cerebral palsy show limb weakness, scissor gait, hypertonicity, and they have, in general, they're quite stiff and they have trouble moving. Then dyskinetic cerebral palsy is associated with damage to the basal ganglia, and these children have slow movement and often writhing movements, and the condition is exacerbated by stress. And then finally, the least common is ataxic cerebral palsy, which is characterized by a wide-based gait and intentional tremor, and a very much disturbed sense of balance, and that is because in this case the damage lies in the cerebellum. And then you can also have instances of mixed cerebral palsy where different areas of the brain are affected. So one of the difficulties with cerebral palsy is that it's actually quite a non-specific disorder, because there's not a clear or defining distinct feature that is easy to identify early. And often children with cerebral palsy are diagnosed because they miss milestones as they grow. So the set of motor impairments which affect the posture and the movement are broad, and they're shown here on the right-hand side. There are a range of causes, and there's also a range of severity from mild, where we're looking at an individual with poor muscle tone, poor balance and posture, to severe, where use of the limbs is severely affected, something like quadriplegia. In addition to these motor impairments, children with cerebral palsy often have additional comorbidities. So, for instance, epilepsy, incontinence, learning, and also hearing difficulties. There are a range of epidemiological and genetic risk factors to cerebral palsy, and there's a list provided here, and we'll just touch on a few of them. Preterm delivery is a significant risk. And this is probably got to do with the fact that the white matter is particularly susceptible to damage in the 26th to 34th week of pregnancy. As mentioned, there are potential genetic causes, and although we now know that it's likely that up to 14% of cerebral palsy cases may be linked in some way to single gene mutations, this is quite a new finding from relatively recent exome sequencing studies. And prior to that, the genetic component was really thought to only be 1 to 2% of cerebral palsy cases. So, for instance, the zinc finger gene, the ZC4H2 gene, when it is mutated, that is thought to increase the likelihood of developing cerebral palsy. Bacterial and viral interlesion infections, inflammatory responses, as one would see in a perinatal stroke, growth restriction and high order pregnancy are also all risk factors, as well as placental issues such as villositis. What's interesting is inborn errors of metabolism can present with cerebral palsy symptoms. So, for instance, phenylketonuria and Niemann-Pick type C, both are types of inborn errors of metabolism that present with cerebral palsy symptoms. In most cases, however, these types of rare diseases can be treated quite early, and if done so, the effects can be reversed. And then finally, males are at a greater risk of developing cerebral palsy than females. This may be linked to the fact that they have the shorter Y chromosome and therefore are more vulnerable to mutations. So the following types of brain damage may cause the characteristic symptoms of cerebral palsy, and I've just given 5 examples. Firstly, periventricular leukomalacia, or PVL. This is characterized by small gaps in the white matter and results in abnormal neurotransmission, and is significantly increased in preterm infants. Again, related to the fact that the white matter is particularly susceptible to damage during the 26th to 34th week. Then cerebral dysgenesis, which refers to abnormal brain development and interrupted neurotransmission, which can result from, for instance, trauma, infections, and even genetic abnormalities. The intracranial hemorrhage that occurs during, for instance, a fetal stroke and results in the flow of blood to the developing brain being blocked can cause significant damage. And this can result from, for instance, placental clots or malformed blood vessels. And then finally, hypoxic ischemic encephalopathy, which results when there is a longer interruption in oxygen supply, and this lack of oxygen then leads to cell death within the cerebral motor cortex, and can result from, for instance, low maternal blood pressure, the rupture of the uterus, and trauma to the head during labor or delivery. So with that background, one could ask, well, why would cord blood stem cells be viewed as potential therapeutic mediators in cerebral palsy? And to answer this question, we need to look at the definition, the different types, and the regenerative potential of stem cells. And specifically here, focus on adult stem cells, which include your umbilical cord blood stem cells and all stem cells that are present in the body postnatally. So we know that adult stem cells are characterized and defined as unspecialized cells which have the capability of self-renewal, so ensuring their population is maintained through the lifespan of the organism, and they're able to differentiate into specialized tissues and organs and thereby exert a specific function. There are two major families of adult stem cells would be the mesenchymal stem cell and the hematopoietic stem cell. So your mesenchymal stem cell gives rise to connective tissue, for instance, your bone and your muscle and fat and cartilage, etc. Whereas your hematopoietic stem cells give rise to your blood cells, your white blood cells and your red blood cells, etc. Mesenchymal stem cells are known to be found throughout the body, and the most common sources would be the bone marrow, the adipose tissue, and umbilical cord blood and tissue. Another type and smaller group of adult stem cells is the neural stem cell. So the neural stem cell is found in the brain, and this stem cell can give rise to neuroprogenitor and glial progenitor cells, which then ultimately give rise to neurons and the supporting. So through this differentiation, the neural stem cells can replace lost cells. In addition, stem cells can also exert their effect through the factors that they produce. And this is referred to as the Paracrine Effect. So the Paracrine Effect refers to the release of and the secretion of cytokines and chemokines from cells, as well as the release of small extracellular vesicles such as exosomes and microvesicles from these stem cells. And these growth factors and cytokines and the exosomes carrying microRNAs, for instance, will take these signals to the target tissue and influence the process of regeneration in that target tissue. So neural stem cells can give rise to these cells within the brain. Mesenchymal stem cells, such as those found in umbilical cord and adipose tissue and bone marrow, are also able to give rise to neural progenitor and glial progenitors. So these mesenchymal stem cells would obviously be found elsewhere and could therefore traffic to the affected area and assist with regeneration. But importantly, this regeneration is no longer thought to be only by this differentiation, but is also thought to be via this so-called Paracrine Effect. So the paracrine signals that are released from these cells serve to influence a wide range of processes, which establish an environment that is conducive to regeneration and functional recovery. Some of these processes are indicated on this slide. So, for example, a change in angiogenesis, the production of new blood vessels, or a decrease in inflammation to make it more hospitable for the cells to be able to, for instance, differentiate and to heal the wound. Pro-survival and anti-apoptotic factors and signals and chemotactic signals, which will serve to facilitate the movement of cells further away from the damaged area into that area. Remodeling of the extracellular matrix, which would be, for instance, the deposition of collagens and fibronectins and other matrix factors, which all serve to provide a conducive environment, but also serve as a scaffold for cells that are migrating into the area. And then finally, activation of the actual stem cells themselves to differentiate into the target tissue. So all of these contribute to what is hoped would be then some type of functional recovery of the tissue. So specifically within umbilical cord blood, there are 5 key cell types thought to mediate the neuroprotective and neuroregenerative effects. And these are shown here on the on this particular image. So we have the mesenchymal stromal cells, which include our mesenchymal stem cells. We have the endothelial progenitor cells, the regulatory T cells, hematopoietic stem cells, and these all have particular roles to play, and some of these roles are overlapping. And you can see that, for instance, your mesenchymal stromal and stem cells, as well as the regulatory T cells and the monocyte-derived suppressor cells, all have an anti-inflammatory role to play. And this is important because an environment that remains pro-inflammatory will not be regenerative. So it has to make that transition into the proliferative phase of wound repair and move out of the inflammatory phase in order for regeneration to be able to happen. Then we have the actual conversion of progenitor cells and stem cells into new tissue. So, for instance, angiogenesis using the endothelial progenitor cells to form new blood vessels, or the differentiation of mesenchymal stem cells, or even resident neural stem cells to become the target tissue. In addition, our mesenchymal stem cells can secrete neurotrophic factors, which can then affect the resident stem cells. And so all of these cells together have a role to play in creating an environment that can promote regeneration. In animal studies, umbilical cord blood therapy has been shown to prevent white matter damage and also to counteract functional loss of neural tissue. And what has been found is the earlier these cells are administered, the better. So in rodent models of stroke or traumatic brain injury, it's been shown that umbilical cord cells reduce the neuronal injury in the perinatal brain, and that the timing of this is crucial, and that administration needs to be within 24 hours of injury in order for that degeneration to be reduced and for improved walking patterns to be observed. In larger animals such as sheep, birth asphyxia and hypoxic ischemic encephalopathy context have shown that umbilical cord blood administered at 12 hours post-insult can restore normal brain biochemical profiles. And in the context of preterm hypoxic ischemic brain injury, if umbilical cord is given within 12 hours of injury, there is significant protection via the oligodendrocytes and axonal myelination. However, delaying that administration to 5 days significantly reduces the efficacy. So there's definite evidence that the earlier the better. However, this obviously poses an issue because, as mentioned earlier, in the case of cerebral palsy, often the diagnosis is made as children develop and as milestones are not met. And so really being able to administer these stem cells very early could be a challenge. Many trials have been done to investigate the application of umbilical cord blood in the treatment of cerebral palsy, and 17 of these are shown here. And I'm not going to go through all of them. The purpose of this is just to give you an idea that there really is a lot of activity in this particular arena. And should you be interested, you could take the clinical trial number shown on the left, and you can put it straight into Google and it'll pull out that particular trial. What you'll notice is that in these trials, both allogeneic as well as autologous cord blood stem cells are being utilized. In some cases, the trials were recruiting, in some cases they were complete, in some cases they were active. but all of them are looking in some way to determine whether the use of umbilical cord can improve symptoms of cerebral palsy, specifically looking at things like gross motor function, visual perception, and muscle strength, as well as presenting follow-up safety data. And in today's talk, I just want to focus on this particular trial, which was carried out under the supervision of Professor Jan Kurtzberg at Duke University. And here they were carrying out a randomized placebo-controlled trial to analyze the effect of autologous cord blood infusion on motor function and brain connectivity in young children with cerebral palsy. So I've just summarized the main aspects of this trial in this slide. You can see the clinicaltrials.gov identifier. The study dates were between 2010 and 2016. And the study focused primarily on spastic cerebral palsy. They were looking at autologous umbilical cord blood, and their primary outcome was to look at a change in gross motor function measures 66 score, so the GMFM 66 score. So this is a clinical tool used to evaluate gross motor function in children with cerebral palsy. And so it's a continuous score between 0 to 100, and a higher score is better and a lower score is worse. But more importantly, one can look at the relative change in the score. And so when you're looking at it this way, then a negative change would indicate a reduction in motor function, and a positive change indicates an improvement, whereas a 0 indicates no change. And that's going to be significant when we look at the next slide. In this study, they enrolled 63 participants. Their enrollment target was initially 120. So the children that were eligible for this trial were between the ages of 1 and 6 years. And the participants had to have a stored cord blood unit that had been stored either publicly or privately. And this unit had to have the characteristics indicated in table 1. So a total nucleated cell count of greater than or equal to 10 million cells per kilogram, at least 80% viability, either total or CD34, the sterility tests and the maternal infectious disease screening, looking at, for instance, Hep B, Hep C, HIV, and syphilis should all be negative, and an HLA test sample should be available for confirmation purposes. And then post-thawing analysis of the sample to run the HLA testing and confirm the identity of the sample and compare that with the subject. The CD34 viability needing to be at least 60% or higher, and growth in the colony forming unit assay. So the CFU assay measures function and ability of stem cells to multiply and tells you a little bit about the quality of the stem cells. So it's quite an important assay to do. So they looked here at 2 doses. They compared what they referred to as the low dose, which is 20 million cells per kilogram, and the high dose, which is, less than 20 million cells per kilogram, and then the high dose, which would be greater than or equal to 20 million cells per kilogram. And what they found was the left-hand graph shows the change in gross motor function, with the red box indicating the low dose and the blue box the high dose. What you can see here is that following the infusion of the low dose, the change in gross motor function sort of hovered around 0. So telling you that there's not really much of an improvement. However, following the higher dose, so infusion of the higher cell number being more than the 20 million per kilogram, a significant increase was seen, and the change in gross motor function was now higher and above 0. So this suggested that there was an improvement in motor function. Then on the right-hand side, we have the normalized connectivity change at 1 year post-treatment. And again, we have the low and the high dose. And here you're looking at changes in the normalized whole brain connectivity, looking to see whether there is more connectivity in the brain post-treatment. And a similar type of pattern can be seen there, where the low dose really had less of an effect than the higher dose, and the higher dose was significantly more efficacious than the lower dose. And I just included at the bottom these images showing the brain, and the blue, light blue and dark blue dots are showing the nodes and the connections between them in the red and the yellow. And anything that's basically blue or red or yellow is showing an improvement or a good change in that normalized brain connectivity following at the 1 year time point. So following this phase 2 trial, one can say that in the children that were recruited, which were between the ages of 1 to 6 years, using the autologous umbilical cord blood infusion in kids with spastic cerebral palsy and a single intravenous fusion of the cord blood, dose of greater than 20 million cells per kilogram improved the whole brain connectivity and also resulted in a significant improvement in motor function, which is really encouraging. And I thought it would be nice to just include a face that formed part of this trial. So Patrick Rooney was one of the participants. He was born with cerebral palsy, which they really only picked up as he was developing. And they found that, you know, his balance was off. He kept tripping. Actually, his right foot was at right angles to his left foot. His coordination was off and his motor planning. And they did an MRI and they found that there was damage to the right side of his brain, and they reckoned that he had had a stroke in utero. And so he then took part in this this trial under the supervision of Professor Kurtzberg. And following the trial, an improvement in motor function and coordination was seen. He no longer trips over his own feet, and he is now an avid athlete and takes part in many athletic activities. So quite a nice story and a nice visual to see how these cells can really improve the life of the individuals. So if you're interested in that particular YouTube clip, the link is at the bottom of the slide. Just copy and paste that into Google, and it's about a 3 or 4 minute video. So if we're going to just summarize beyond the single trial that I've looked at, all the various trials that have been carried out, then we can say that umbilical cord blood stem cells in the context of cerebral palsy are safe. There have been, at this point, probably more than 4,200 cerebral palsy patients involved in various trials around the world. They have shown significant effects at as early as 6 months to a year. And this is looking at motor performance, gross motor function, cognitive and motor developmental outcome, functional independence in daily activities, and muscle strength and hand function. What's clear is the dose and the timing is important. The higher the dose, in this case, the greater the effect with respect to normalized total brain connectivity as well as motor function. And soon after injury is better, probably because it gives the cells time to exert their immunoregulatory and neuroprotective effects. So I want to end off just going back to mechanism and just bringing some of these factors together. So if we think again about umbilical cord containing these different cell types that were referred to earlier, then you can imagine that they would all play their part in promoting regeneration. And the 3 main aspects that we're talking about here is the enhancement of neuroregeneration and homing. We are looking at trophic factors and their secretion and immunoregulation and neuroprotection. And so what you could have is, in the case of a brain injury, we know that following a hypoxic event, the expression of cerebral-derived factor 1 is upregulated in the brain. And so that's shown here, and its receptor is CXCR4, and CXCR4 is expressed at high levels on, for instance, hematopoietic stem cells and mesenchymal stem cells. And a great aspect of particularly hematopoietic stem cells, but also to a certain extent mesenchymal stem cells, is their ability to home. So following an injury or with an existing inflammatory area in the brain, these cells could home to that area, and once they're there, they would probably be most likely to secrete many growth factors, and these growth factors would have an effect on the resident stem cells, such as the neural stem cells, and potentially also your endothelial progenitor cells, promoting differentiation into the different brain cells, as well as your angiogenesis. The cells would also release extracellular vesicles, which contain, again, growth factors and microRNAs, which would further promote the regenerative capability of the endogenous cells. The recruitment of your regulatory T cells and your monocyte-derived suppressor cells into that area would provide a certain amount of immune regulation, would reduce the inflammatory environment, and promote the ability of, again, your endogenous cells to heal that area and to promote the neuroregeneration. So I'd like to just end the presentation by saying that this is the first in the NetCells medical series, and NetCells is a company of Next Biosciences, which is a private stem cell bank established about 15 years ago. Our laboratories are situated in Midrand, and besides NetCells, there are 3 other companies that form part of Next Biosciences, including Next Genetics, which is involved in reproductive genetics, Placenta, which is involved in regenerative biological products from the placenta, and Hexalabs, which looks at health and lifestyle tests. So with that, I'll end this talk and take any questions. Thank you.
Thank you so much, Carola. That was very informative and I really enjoyed it, so thank you. We've got 2 questions here for you, and I also want to let everyone know that our medical director, Dr. Yvonne Holt, is also online if there's any questions for her as well. But we've got a question here that says, how long has NetCells been in South Africa? And should there be a need for release, how would we be able to coordinate that?
All right, so I think most probably Yvonne can answer. NetCells has been around since 2005, but Yvonne can probably take over.
Yeah, thanks, Carola. Thank you for an excellent presentation. So NetCells was first established through Netcare, actually, in 2005. We have been around for 15 years. After being with Netcare for 2 years, we then became an independent business and have been so for the last 13 years. Should you wish to retrieve your stored cord blood units, it is a pretty simple process. We do need a permission from a treating physician, so you would have to have an established diagnosis and a treatment center that would administer the stem cells. We have a formal process that goes according to our accreditation with the American Association of Blood Banks, and basically we would communicate with your treating center and the treating doctor. There's some forms to be filled out, and then we would send the cord blood unit in frozen to the cryo shipper to the medical facility that will be administering. That facility will then thaw those stem cells and administer them as needed.
Fantastic. Thank you so much, Yvonne. And then we have a question, just one last question here. I think it might have been before Carola answered this, but it was, where do you find neural stem cells, and are these particular cells present in the cord blood?
Great. So that's a great question. So neural stem cells, the actual neural stem cells themselves would be found in the brain itself, but you aren't going to find them necessarily in the cord blood. But what you will find in the cord blood would be your mesenchymal stem cells, which can give rise to neural cells. So they aren't classified as neural stem cells, but they have the capability of differentiating into cells of the brain.
Wonderful. Thank you so much, Carola. We don't have any more questions. I just wanted to mention with the question of can we get get stem cells to a treatment facility? We actually have facilitated the release and transport of stem cells for two clients, and they actually went through to Duke University for this particular clinical trial. So I think that's really, really exciting to know that it is absolutely possible. We can facilitate the transport of these samples, and that it was actually available to international clients as well, and international patients. So thank you very much, everybody, for joining us, and thank you so much to Carola for her presentation. And we hope you all have a wonderful evening, and that you have gained some knowledge on what cord blood stem cells can be used for. So we hope that you will join us for our next installment in the NetCells Medical Series. And yes, have a wonderful evening.